right? So now it backs up to that left atrium, like you said. And then from there, it backs up into what? The lungs, okay? So whenever we're talking about left-sided symptoms of heart failure, we're going to think of those that are pulmonary in nature. Pulmonary edema, okay, shortness of breath, these type of things, because this blood is backing up into the lungs. From the lungs, it goes to right ventricle, right atrium, to the body. So the right-sided symptoms are going to be those peripheral edema, and those type of things. Okay? Does everybody understand that so far?
Yes.
So we understand how blood flows. We understand what the problem is in most heart failure. Now, there is some heart failure where there is what we call a preserved ejection fraction. So the ejection fraction is normal, but they still have heart failure. But most of what we see is going to be those where the ejection fraction is low. And then we see the opposite of this. Okay? Does everybody understand that? Any questions? Please don't hesitate to ask any questions that you may have, okay? Don't let me be the only one asking questions. Okay, so now we can either classify or stage heart failure. Okay? You guys heard of New York Heart Association, class 1, 2, 3, and 4? Yes?
Yes.
Okay. So, somebody tell me what is class 1? What happens in class 1? Class 1 heart failure, what happens? You have symptoms. You have symptoms on normal exertion or normal activities. Okay? Wait, hold on. Excuse me. You have symptoms at levels of exertion that were not normal levels. You're having to actually do some sort of physical activities, okay? Whereas the normal person without heart failure would not have any symptoms, you would have symptoms doing these type of things, okay? The class 2, okay, class 2 is gonna be on your ordinary exertion, like what I just said for class 1. You're comfortable at rest, but on ordinary exertion, you start to have symptoms. If you get up and walk around this room, you may start to get some symptoms. Okay? And then class 3 is going to be symptoms with less than ordinary exertion. And then 4 is going to be symptoms even at rest. Okay? But the thing that I want you guys to know about the New York Heart Association classification, that is it's all based on your symptoms at that time. How are you feeling right then and there? Okay? And because of that, you could be class 2 or even class 3. We could provide you with some medications, and those symptoms may resolve some. So you may go from being class 3 to class 2 with just the use of medications. You can go kind of back and forth with the New York Heart Association because it's how you're feeling at that moment. Whereas we can actually stage heart failure. A, B, C, and D. Okay? ACC, AHA, staging of heart failure. That's where that's where we've moved towards. We moved towards that because it shows heart failure as more of a progressive disorder. All right? So can somebody tell me what happens in stage A? Need some help. Stage A. What do we got?
You're at high risk.
Okay, risk factors.
to hypertension, dyslipidemia.
So that was my next question. So what are the risk factors? Yeah, you're gonna have uncontrolled diabetes, uncontrolled hypertension, dyslipidemia, maybe overweight, okay, sedentary lifestyle, maybe somebody smokes. So you don't have heart failure, but you have the risk factors that can kind of push you in that direction. Okay? Stage B is what? Structural, right? Structural happens a couple of ways. One, we just talked about, right here. That left ventricular hypertrophy, that left ventricle, you know, trying to get that, push that blood out, pump that blood out, it starts to get misshaped, and now the heart is structurally damaged. Okay, that's one way of it. That, you know, usually takes time to get to that point. Another is if you have an acute, like a heart attack or something, you know, when you have a heart attack, that can physically, structurally damage the heart. So we'll pause there.
Good morning.
Good
You
morning.
can finish your sentence if you want. I don't want
Okay, just real quick.
to. Yeah, please do.
So, stage B is the structural damage that we just talked about. Stage C is what?
So you're in heart disease, damage to the heart.
It's now you're having the symptoms. You're having what we talked about a little bit earlier. You're having the peripheral edema, pulmonary edema, the shortness of breath, okay, rales, ascites. We'll talk about symptoms in a little bit. But stage A, you don't have anything, you just have the risk factor. B, now we're seeing the structural damage, either with an acute MI or, like we said here, with this left ventricle that's now become misshaped, okay? Stage C, now we're seeing the symptoms are starting to come into play, okay? So we said this ventricle has been misshaped. We said that the blood now, instead of going forward, is backing up, right? So now it's backing up into the lungs. Now we're starting to see those pulmonary symptoms. It's backing up to the body. We're starting to see those peripheral symptoms. That's here, stage C. Okay, then of course stage D is gonna be the refractory stage, and that's where we're looking at, you know, frequent hospitalizations, those patients who are maybe hospice, or those patients who maybe can get a heart transplant, or at least on the heart transplant list, okay? So you see with classifying versus, staging versus classifying, you see it progress, correct? We see it progress from one to the next. Whereas symptoms, we can kind of go back and forth depending on how you are able to maneuver in your daily life. And you have symptoms at rest, do you have symptoms on normal exertion, do you have symptoms on maximal exertion, do you have symptoms on minimal exertion? Back and forth with classifying. Okay? Everybody understand that?
Yes.
Any questions? Okay, I'll pause there.
Oh, thank you, sir. Thank you for letting me come to class.
Mhm.
Somebody put a timer on 5 minutes, because you know I talk too much. Seriously, grab a phone, put a timer. Somebody's got it? 5 minutes. Got a phone? Put your timer on 5 minutes with a ringer. When that ringer goes off, I'll shut up. Because otherwise, I'll be here 45 minutes into your lecture. So I came to talk to you. Good morning.
Good morning.
Was it okay? So something was, I think, slightly miscommunicated to you. So I came to apologize and remind you. You all received this email about the ABCs of entrepreneurship with UTMB. This is the contract I signed with UTMB so they can do this for you. So we had a meeting the other day on the 21st. Next meeting is on March 7th. Only 11 of you showed up to that meeting on Monday. I want all of you there. All of you. This is serious. I should have come and told you how important this is. So remember, I'm a pharmacist. I'm some 30, 40 years ahead of you. I have 3 licenses in 3 different states. I'm not smarter than any of you, but I'm your tour guide. As your dean, I'm your tour guide. You're so bogged down with these lectures, I come here and say, hey guys, this is gonna change your life. This series of lectures on entrepreneurship from UTMB are amazing. This is you 5 years down the road, 6 years down the road. You gotta take care of this stuff here and these stages. I get that. But occasionally when I see something where I'm like, oh my God, my students need to know this. They need to go to this. This is serious. We're gonna go on their campus. We're signing all sorts of contracts with them. As you know, UTMB is a phenomenal institution in Texas, in the country. So please, and again, my fault, I should have come to you earlier. March 7th, April 4th, May 2nd, it's only an hour, it's virtual. You probably are at home, log in and listen. Entrepreneurship doesn't mean you're gonna go open the store. So those of you thinking you're gonna go work at a hospital or Walgreens, oh, it's not for me. That's not the point. Entrepreneurship is critical thinking about what you were just presented. It's about taking an idea from science to the market. And these guys are absolutely top notch. So I have 230, 40 of you in the college. Come March 7th. Again, think of me, I do a lot of different things for you, as you know. But think of me also as your tour guide. I'm just ahead of you by some 40 years. So when I see a trend, when I see an opportunity for you to become nuclear pharmacist or cardiology pharmacist or oncology pharmacist, great opportunities, I'll bring those to your attention. This is one of those. They're gonna be on campus, they're gonna talk to the fourth year students. This is a long-term relationship I'm building with UTMB. Some other stuff's gonna come up, so please, I'll have Cynthia Johnson send this to you again, but just sit back, relax, and listen to these guys. And down the road, you're like, wow, I'm so glad I got exposed to UTMB's entrepreneurship lecture series. How am I doing with my time? I still have 2 minutes left, see? Fantastic. Questions for me at this point? I don't want to get into the lecture. Thank you, sir.
No problem. Let me just make a statement in regards to what he's saying. I've been practicing pharmacy. I graduated from TSU in 2007. Did my residency after that, and then I went to work at the county doing clinical pharmacy. I did that for 8 years, and now I've been back at the VA for 5 years. So I've been practicing for a good while. But I do other things outside of pharmacy, entrepreneurship-wise. And I will tell you, because being an entrepreneur, you know, you're gonna have, you know, better days, better months than others. But there's been several months where I've made more money with my other stuff that I have going on than actual pharmacy, sometimes double. And so take what he's saying seriously, because pharmacy just gives you a means to kind of, you know, take that and run with it in any field that you want. Any field that you want.
Exactly. And I thank you for giving a true example of a person standing in front of you who is a TSU alum. But again, think of me when you see these things, and I'm happy, and again, I'm sorry I didn't come earlier, but now you know, when you see these emails from Cynthia Johnson, think of you're in Disneyland or Disney World, and I'm your tour guide, and I'm saying, hey, pay attention to that building. Check that one out. Again, I know you're bogged down with lectures and integrated exams and all that other stuff, but take a little time, because this is gonna bear fruit later. Thank you, I appreciate it. Sorry for the interruption, guys.
No problem.
I'll see you later. Thanks.
Okay, so we're good with staging, we're good with classifying, we're good with the heart and how blood flows. I can erase this?
Yes.
All right. So we talked about left and right sided symptoms of heart failure. A lot of times, most of the time, patients will present with both, okay? But I wanted to make that distinction so if somebody asks you, you know, left-sided versus right-sided symptoms, you have a general understanding of that, okay? So, give me some symptoms. Heart failure, what do we see? Shortness of breath for sure, right? What else? Give me some symptoms. What's that? Fatigue, absolutely. What else? Edema, peripheral or pulmonary? Pulmonary or peripheral, absolutely. 2, 3, 4 plus pitting edema. You can, you know, I've had patients where I was able to stick my finger into their leg and it just went like all the way in. You know, that's a lot of fluid that somebody is holding. Okay, what else? What else? What else? What else? Chest pain, cough, right? Okay. What are rails? You heard of that before? Crackling and hissing sound, right? From the lungs. Okay. JVD, what's jugular vein distension? What's that? This vein here that's protruding out. Okay. These are all symptoms that these patients will present with. But most often than not, we're going to see shortness of breath, fatigue, we're going to see edema, peripheral or pulmonary. Okay? Those are the ones that you will see mostly. The rails, the crackles, you can't really hear that unless you have a stethoscope. JVD, you can see that vein is distended. But those are the ones that you will see most of the time. All right. So, what are our goals of therapy? What are we trying to do with these heart failure patients?
Improve their quality of life.
Improve quality of life, absolutely. What else? Slow disease progression, absolutely. Okay, we want to slow it. If we can keep it maybe at here, stage B, as long as possible, okay, then that's good. Okay, or even when we get here to stage C, we want to keep it here as long as possible. We don't want to get here, because once we get to D, then we're really having some problems. Okay, what else? You said slow disease progression, improve quality of life. What else? Symptoms, right? Relief symptoms. Okay, and then of course our morbidity and our mortality, and survival and hospitalizations. We want to increase survival. We want to decrease hospitalizations. Those are going to be our goals of therapy. That's what we're trying to do. All right? Okay. So before we get to medications, let's look at lifestyle. What are some lifestyle changes that some of these patients need to make?
Eating more healthier,
Eating more healthy. What does that mean?
probably diet, so they would have to work on their diet.
What is a DASH diet?
The diet is
Hypertension, so like leafy greens, protein.
Oh, and your grains, your fiber.
Okay. So dietary is going to be a main one. Okay. We want them to eat as healthy as possible. Lean protein, chicken, fish, turkey. You know, not fried, preferably. Okay. As much vegetables as they can, they can take. Fruits. If they're not diabetic, of course, those that will help. But what is the big part of the diet, in particular for the heart failure, that we need to keep an eye on?
Reduce sodium.
Sodium, right? Salt. Because if you do that, then you're going to retain fluid, right? It's going to worsen their symptoms. Okay, so dietary restriction, salt restriction. In some cases, even water restriction, because if these patients have a lot of fluid on them, we're going to have to limit their water or their fluid intake just in general. Okay? All right, so what else outside of dietary?
Exercise.
Who?
Exercise.
Exercise. What are we doing exercise-wise? I'm the patient. What are you telling me that I need to do?
Does it depend on what classification you are? Because some people can only walk around their house.
Okay, so it's going to be physical activity as tolerated, right? Okay, whatever it is that you can do. All right. So somebody who is stage C and they have a bunch of stuff going on, they're not going to be able to do as much as somebody who is stage A who doesn't have anything yet. They just got those risk factors. So those are the ones we're going to push. You need to try to do some physical activity, walking, running, swimming. Most days of the week, every other day. Don't go a couple of days in a row without doing some sort of physical activity. But then you have the person who is stage C who may be only able to walk for 5 minutes and that's it. Just as much as they can tolerate. So it's gonna depend on from patient to patient, right? Okay, what else? Physical activity, dietary, what else?
Pharmacologic therapy.
You smoke.
Smoking cessation, right? What else?
Reduce your alcohol intake.
Okay, alcohol intake, modestly, okay? All right, what else? Adequate rest, okay? What about clothing? Yeah, you don't want, you know, clothing that's a little, you know, form-fitting or tight. Somebody who has a whole lot of edema and they have on, you know, some really tight socks or stockings or things of that nature can present as a problem as well, okay? All right. So all of these risk factors that the patient has for heart failure are what we're trying to kind of see if we can get some sort of hold on, whether it's lifestyle, okay? And then of course we're also gonna want to avoid certain medications that may worsen heart failure, more specifically heart failure symptoms. But we'll talk about that later. All right? So far so good? Okay, so we're able to classify, but more so stage heart failure. We know how the heart and the blood flows and what happens when it backs up, right? We know left-sided versus right-sided symptoms. We know symptoms in general. We know where our goals for these patients are, as well as how we're trying to achieve those with lifestyle modifications. All right? So now we get to medications. All right? So now medications, I want you guys to break these medications down into 3 separate categories. All right? First one is gonna be MM. What do we think that stands for?
Morbidity, mortality.
Morbidity and mortality. Okay? 2, it's gonna be symptoms. Okay? And 3 is really a miscellaneous. Okay? But morbidity, mortality, symptoms, and then of course miscellaneous. All right. So let me ask you guys, have you guys started reviewing journal articles yet? Yes? How'd it go? Not that great? All right. So, what is the difference, if we're looking at articles, what is the difference between an endpoint and an outcome? They're used interchangeably all the time, but there's a distinct difference between the two. Endpoint, outcome.
So like, I would say like endpoint is pretty much like what you, I guess, want to prevent, like what stops you from going further. So like death, heart attack, stuff that you're trying to prevent.
That's an endpoint or the outcome? That's an endpoint?
Endpoint.
So what would be the outcome then?
Outcome is like what was the result of what your study was trying to prove.
Based
They
on
sound
that.
basically the same.
Yeah,
I get it.
yeah. Anybody else? That's a good response. Anybody else? No.
The outcome more so what you were looking to,
Okay.
like like how sometimes they do a study and they're looking for something in particular.
And then they get something
But
else.
if they get something else,
Okay. Maybe
And
so.
that is like a secondary endpoint.
Expectation?
Okay, so let me phrase the question this way. Let me give you 2 things. You tell me which one is the endpoint, which one is the outcome. All right? 1, lowering blood pressure. 2, decreasing cardiovascular event. Which one is the endpoint? Which one is the outcome?
the outcome is
reducing blood pressure, reducing cardiovascular events. Which one? Okay, which one is the endpoint?
Reducing cardiovascular.
Reducing cardiovascular events, and then that's the endpoint, and then the outcome is reducing blood pressure. That's what we're saying. It's the opposite. So the endpoint is the reduction in blood pressure. Okay? Now, because of you lowering that blood pressure, now you're seeing a reduction in cardiovascular events. That is the outcome. Okay? Reducing blood sugar. That's the endpoint. Now, because you reduce the blood pressure, now you see a reduction in lower limb amputations. That is the outcome. Okay? We all can come out, let's say we're a drug company, all of us, and we come out with a new blood pressure medication. All we got to do is make sure that it works, it lowers blood pressure, and it's safe, right? We bring it to market, okay? So now, all we have is endpoint data, right? Reducing blood pressure, okay? For us to show that now, not only does it reduce blood pressure, but it also reduces hospitalizations, it reduces cardiovascular death, it reduces cardiovascular events, we have to do more studies. You know what I mean? Those studies take long time, right? Because we're looking at events, we're looking at deaths. Those take a long time. So our drug is out there on the market, but all it does is it shows that it reduces blood pressure. But you have these other blood pressure meds that have outcome with them, right? Your ACEs, your ARBs, you know, they not only lower blood pressure, but they're renally protective in diabetics. They have mortality benefit in heart failure patients, this, that, and the other. So our medication is not going to move the needle. Our medication is not going to. It's going to sit. Because for one, it's more expensive because it's brand new. You have these older medications that not only have endpoint data, but they also have outcomes. All right? So that's the difference. So the reason why I talk about that is because here, morbidity, mortality is outcomes. All right? These are outcomes, not just simply endpoints. Okay? The statin lowers your LDL. That is an endpoint. But because we see that reduction in the LDL, now we see a reduction in cardiovascular events. That is the outcome. All right? So, when we talk about heart failure medications, ones that have morbidity and mortality benefit, the first ones I want you to look at are the ACEs. ACE inhibitors. Okay, this is now pharmacology. You guys already should know how they work, so we're not going to focus on that. Okay? But we know that ACE inhibitors have morbidity and mortality benefit in heart failure patients. They reduce deaths, they reduce hospitalizations. Okay? We won't talk about how they work. We already know that. Okay? So, if a patient is we have a patient who has heart failure, an ACE is one that we hope that they're on, if they can tolerate it. Okay? So, morbidity, mortality benefit, ACE inhibitors. All right? Now, but I said if they can tolerate it. Why might somebody not be able to tolerate an ACE? Side effects like what? Angioedema, cough. Okay? So, what is angioedema? Swelling of what? Right. Throat, all this, right? Okay. So, angioedema. If they have that, then we don't want to use ACEs at all. Some say you don't even want to use an ARB, but for sure, okay? Angioedema is one. Somebody said cough, right? Okay, now, cough. This cough is not, it's not something that, more so, it's just more just like annoying than anything. You know what I mean? It's not like the cough is causing them any issues or anything like that. It's just a dry cough. But we see that with the ACEs. Okay, do we know why we see those with the ACEs? Increase in bradykinin, right? Okay, because ACE actually breaks down bradykinin, but when you inhibit it, you get elevated levels. So that's where the cough comes from. All right. So with that, oftentimes we'll just switch them to another medication. Okay. Let's be careful with potassium. Okay, with these ACEs. All right. But with ACE inhibitors, if a patient with heart failure can tolerate it, we want to put them on that if possible. Everybody got that? And if they cannot tolerate it from some of these things we talked about up here, then we can switch them to something else. Okay? Oftentimes, we will see the cough maybe about 20% of the time. I mean, but once again, like I said, it's more of an annoying thing than anything. Okay? Also, let's monitor our kidney function, okay? Because it may make us come off of that. Okay, B, our ARBs, our ARBs, angiotensin receptor blockers, okay? Once again, we're not talking about how they work, but they have morbidity and mortality benefit. And if somebody has a cough with an ACE, would we expect them to have it with the ARB? No, right? Because it's past that bradykinin pathway. It's when it actually binds to the receptor. So there's usually no cough, but all these other angioedema, be careful with potassium and kidney function, all are associated with the ARBs as well. Okay? And so if somebody has angioedema with an ACE, you can try an ARB. Oftentimes they say you shouldn't, okay? But just know you can have the angioedema, you can have the elevated potassium, you can also have have to discontinue it based off of serum creatinine with the ARBs, okay? But morbidity, mortality benefit with both of these. They should not be on both, right? One or the other. Everybody got that? We're sure? All right, you guys don't slip up. Okay, so now, there is a new class, well, relatively new, that has we call them what, the ARNI, right? They have the ARB and the neprilysin inhibitor. Have we heard of that drug?
No.
No. We have, no, not allosterin. Allosterin is the direct renin inhibitor. Okay, so you guys have not heard of Entresto? What's Entresto? What's an Entresto? Valsartan is the ARB, and the sacubitril is the neprilysin inhibitor. So Entresto, okay? So, once again, morbidity, mortality benefit. But this one actually has shown to reduce mortality, okay? I want to say by over 50% over these two. So this actually is better to use than an ACE or an R by itself, okay? Before it was ACE or an R, absolutely. When this came out, it was still ACE or an R, right? But if the patient was still not doing that well, then they would say, okay, we can do this. But now they're saying we should use this out of the gate. Okay, so this has the ARB in it. So because it has this, then we still have to worry about 3 of these 4, right? The only one we don't have to worry about is the what? Cough. So we don't have to worry about the cough, but we still have to worry about the angioedema. We still have to worry about, elevated levels of potassium as well as serum creatinine. Okay? So we're going to see I think it was compared with enalapril. And I think you see 20, maybe 30% greater reduction in hospitalizations and cardiovascular death with Entresto over the ACE by itself. Does everybody get that? Everybody understand? Yes. So when you compare Entresto, valsartan, and sacubitril to enalapril, okay, the ACE, there was like, I believe, 20 to 30% greater reduction in cardiovascular death and hospitalizations with Entresto. So because of that, that's why it's kind of moved up the food chain per se, okay? Because what we're looking at outcomes, cardiovascular death and hospitalizations. Evidence-based, right? That's what I'm assuming that they're teaching you guys. Evidence-based medicine, right? And so when the study came out showing the greater reduction with this, then the evidence has shifted things. Okay? So far, so good. Questions? Okay, I feel like I'm the only one talking. So, remember, angioedema, potassium, serum creatinine. Be careful with those, okay? All right. Now, one thing I want you to know, if you're switching, let's say a patient's on enalapril, and we want to switch them from enalapril to Entresto, okay? We want to wait 36 hours after that last dose of enalapril before we start the Entresto. Okay? Enalapril, and we're going to switch to Entresto. We're going to wait how long? Okay, very good, very good. Let's say we want to switch from losartan to Entresto. How long are we going to wait?
36 hours.
It's an ARB too, right? So you don't have to wait. Only if you're going from an ACE to that, they want that 36-hour washout period. But if you're going from one ARB to another, you don't have to. Yes, ma'am.
What is ARNI stand for?
Okay, so ARNI, okay, is going to be your angiotensin receptor, which is the ARB part, right? Which is the valsartan, angiotensin receptor, and then the NI is the neprilysin inhibitor, which is the sacubitril.
Thank you.
No problem. We got that? Everybody so far so good. We not gonna get tripped up on the washout period with losartan, are we? No. Right? Okay. Next one that has morbidity mortality benefit. BB, what's that? Beta blockers. Okay? But now, please listen, with the beta blockers, it's not a class-wide effect. So not all beta blockers have the morbidity mortality benefit. There's 3. Do we know those 3? What's that? What'd you say? Which metoprolol? There's 2 different ones.
Succinate.
Metoprolol, succinate. It sucks to have heart failure. Succinate. Okay. What's the second one? Carvedilol. Carvedilol is the alpha and. Okay. Carvedilol. Correct. Right. And the last one. That's the one you don't see as much. I can't hear you. Close. Not east.
Isoprolol.
Not labetalol. Starts with a B.
Isoprolol.
Bisoprolol. What happened? What happened? What happened? You said it wrong? What were you saying? Oh, that's close enough. I just couldn't hear you. I gotta speak up. I'm way up here. Usually, when I do lectures, I make everybody sit like on the first 4 rows. But because of COVID, I can't do that. But I'm telling you, I used to. I used to go, and there will always be some students who would try to fight me. They would still, I'd go back there and sit with them until they came to the front. Yeah, so I can hear you guys can hear me. But I can't do that with COVID, so that's fine. So these 3 beta blockers, okay, have morbidity, mortality benefit. Metoprolol succinate, not the tartrate, not the immediate release, the long acting. Carvedilol and bisoprolol. What's the brand name of bisoprolol? Zoveta. Listen. You guys, for me, I might ask you this one because we talked about it, but I don't really ask brand and generics, but it's very important to know your brand generics for the nameplate exam. Because you're going to get some questions that's just strictly, what is the brand name of this? You don't want to miss those questions. You want to miss something you have no idea about. Cystic fibrosis or something. You don't want to miss the brand. Okay, so it's a beta. So these 3 beta blockers have morbidity mortality benefit. Okay? Now, I want you guys to know this as well. If you have a patient on a beta blocker, right? The beta blocker is there for the mortality benefit, morbidity benefit. But let's say that patient gets hospitalized for whatever reason. Let's say it's a CHF exacerbation or whatever, okay? The beta blocker has to be stopped while they're in the hospital, okay? Because it can worsen things in that type of state, okay? So you stop it while they're in the hospital. Once they're stable and they're being discharged home, you put them back on it. But if you have a patient that's hospitalized and they're on a beta blocker, that beta blocker must be stopped. Because it can further exacerbate the heart failure when a patient is in that specific state. But when they're stable, we want them on it. Why? Because it hopefully will keep them out of the hospital and 2, keep them alive longer. We got that? So atenolol? No? Propranolol? Labetalol? Somebody labetalol? Right? Okay. So those beta blockers, morbidity, mortality benefit, okay? Now, because they're beta blockers, we have to be careful with what? Heart rate, right? Because they can, because somebody has a heart rate of 50, 45, do we want them on a beta blocker? No. Maybe not, right? Okay, so we gotta be careful with that. And then of course, BP, blood pressure in itself, but heart rate is the bigger deal. Okay, but blood pressure too. You want to monitor systolic blood pressure and heart rate. Okay, if they're already bradycardic, we might be a problem. What we may have to do is lower the dose. Okay, if somebody's on max dose carvedilol, 25 milligram BID for the heart failure, but they're somewhat bradycardic, maybe we need to go down to 12.5, 6.25, or even 3.125, okay? Because them being on the beta blocker, not necessarily the dose, is what is having the mortality and the morbidity benefit. So if we can get by with a lower dose, then why not, right? Because it's not a dose dependent in regards to the morbidity, mortality benefit. We got that? Everybody? Yes? Okay, running out of room down here. Okay, next. When I was in school, we called these drugs potassium sparing diuretics. Now we call them aldosterone antagonists, which are what two? Spironolactone and eplerenone. Okay? Oh, I didn't spell that right. So these are aldosterone antagonists, morbidity, mortality benefit. Okay, spironolactone, it was the RAILS trial. Okay, RAILS, R-A-L-E-S. RAILS trial that showed spironolactone 25 milligram daily had mortality benefit in heart failure patients. spironolactone can do other things. It can lower blood pressure, right? We already said those are just endpoints, okay? But what we're really looking for is the mortality benefit that we see with it, okay? 25 milligrams spironolactone. So if somebody's on spironolactone 100 milligram BID, they're probably using that spironolactone for something else, okay? They're not using it for heart failure. The heart failure dose for spironolactone is 25 milligrams daily. Okay? All right, and the eplerenone. Okay, so now, side effects. Spironolactone, what do we see? Yes, hyperkalemia. What else?
I don't understand.
What is gynecomastia? Okay, so it's the formation, right? And not just the formation, but it's actually very painful as well, okay? Spironolactone is not specific to just this aldosterone antagonism, okay? It kind of messes with the estrogens and androgens and stuff like that, and so that's where you see the formation of these breasts. And it's, like I said, it's not just the formation, but they're kind of tender, very painful. And so eplerenone is very specific to its aldosterone antagonism, so you don't see that usually with that. Yes, sir?
So would this be more prevalent in younger patients versus older patients, or is there like a difference?
No, not necessarily. Because more often than not, your heart failure patients are going to be older, right? So you don't, I had a few cases where they were younger, mostly younger men that I saw with heart failure, but they're usually older, okay? But on that note, when I was at the county, I had a patient, how old was he? It's been so long. I probably started seeing him when he was in his late 20s. So let's say 32, 33. Ejection fraction, 17%. So what do you think, outside of something being congenital, right? Like you're born with a heart defect. Outside of that, what would you think would be going on to somebody that young whose heart is, in essence, the heart of a 70 or 80-year-old? What do you think could have been going on? What's that? Nah. Well, I mean, let me say that it depends on what you say he's smoking. But just smoking cigarettes or nicotine wouldn't do that, especially at that young of an age. Obese? He was a little bit overweight, but no, that was not it. MI? Why would somebody that young have an MI?
Is he happy?
Genetics. Family history, something.
Tell us.
Yes.
I want you guys to critically think. Think about somebody young. He said smoking, and I said no, not smoking nicotine. And then even just smoking in general. But what would somebody young be doing that could affect their heart? What'd you say? Drugs. Not necessarily meth. His drug was cocaine. What does cocaine do? It's a stimulant. It makes your heart go. Makes the heart just go. So he's like, all his buddies, they did it, when they was younger, and he said he was the one that was unlucky because, everybody else's heart was fine, but his wasn't. So it was his cocaine use. So the cocaine use is what you have a 32-year-old with the heart of a, 80-year-old, 70-year-old. 17% ejection fraction at 32 years old. Okay. So, eplerenone, if the patient is having gynecomastia, eplerenone would be, with gynecomastia with spironolactone, eplerenone would be the better choice to go with, okay? You could just say eplerenone is probably the better choices in general because, like I said, it's more specific to its antagonism of aldosterone, but spironolactone is still used quite a bit, especially because at the lower dose, at that 25 milligram dose, we tend to not see it as much. But, it's still a possibility. And you tell any patient, man patient, like, I'm gonna put you on this drug, it may cause you to, they probably not gonna wanna take it, right? So, but yeah, so, our aldosterone antagonists have morbidity and mortality benefit. Let's keep an eye, because of the aldosterone, let's keep an eye on potassium, let's keep an eye on the serum creatinine as well, okay? Let's keep an eye on those things, because we may, depending on what the level is, we may have to stop it or switch to something else. Everybody good? Questions, concerns? Y'all let me know if I'm running out of time. We got, what, 50 minutes? It ends at 11:50, right? Okay, yeah, we're doing pretty good on time. Okay, F, the next one. This is a new one for heart failure, mostly used in diabetics, are SGLT2 inhibitors. Have we heard of those?
Yes.
Give me an example.
Farxiga.
What is Farxiga? Generic name.
Dapagliflozin.
Okay. Jardiance, which is empagliflozin, right? So these are our sodium glucose transporter 2 inhibitors. Okay? And so what they do in essence is they just cause you to kind of urinate out sugar. Okay? So it will ends up lowering your blood glucose, which is a end point. So when the drug first came out, it was for solely for diabetes. It lowered blood sugar by causing you to pee out the excess sugar in your body. Okay? But as it was studied longer and longer, remember our hypertensive drug that we as a group was going to come out with, right? We said it lowered blood pressure. But you have to do studies over time for the outcome-based benefit. So with the SGLT2, it lowers blood sugar as the endpoint. But over time, they showed that it actually reduced heart failure, hospitalizations, and deaths, which are the outcomes. Okay? So SGLT2 inhibitors also have mortality benefit. We, at the VA, because we're the VA, we have a pretty strict formulary. And so there's certain medications that are on our formulary, but they're restricted. So you have to meet certain criteria for it. And so for the SGLT2 inhibitors, initially they had to try 3 different diabetes medications before they could get approved for that. Okay? But then when all these other literature started coming out, that now you don't even have to be diabetic to get the medication because of the benefit that you see in heart failure patients. Okay? To the point where this medication is used so much for diabetes and heart failure that now it's just strictly formulary. So I've seen the criteria change based on the evidence. Right? Remember we said evidence-based medicine? That's what I've seen. Yes, ma'am.
If someone doesn't have diabetes, what will be the need in excreting glucose through the urine?
There is no need for that. The need is the mortality benefit. Right. Right. But you're going to see that happen though, right?
Yeah.
Right? So usually with that medication,
That's not why it reduces, pretty much. Is that it? Like that's
Right.
That's what it does.
but that's not why. Exactly. Exactly. So with that medication, you see a reduction in blood glucose, right? But you don't see as significant a reduction in blood glucose, because if you did, then you would not probably want to use that on a non-diabetic patient, because at that point you may be worried about their blood sugars dropping too low. But because it doesn't reduce blood sugar that much, you don't have to necessarily worry about that. Okay? But you do see the benefit of it. Yeah. It's not that it's causing you to pee out the sugar the benefit is that it's keeping you alive even though you have heart failure. It's keeping you out of the hospital even though you have heart failure. It's like a 25% greater reduction in hospitalizations by using that medication.
The benefits just outweigh the risk.
Absolutely.
Okay.
Not all the time, but yeah, in that sense, yes. But because this medication, how it works, causing you to urinate out sugar, what do we have to be careful with? Yeah, you're gonna see, mycotic or urinary type infections, right? Because, wherever sugar is, that's where organisms wanna be, right? So I had, when I was at the county, I had some of my female patients. I'm at the VA now, so I don't have as many. But some of my female patients would have, a lot of yeast infections, right? But that's because the diabetes was so uncontrolled. You have so much sugar in the body, these organisms just want to, they want to attack that sugar. And so when you're urinating out the sugar in the urinary tract, now we have issues with urinary type infections, UTIs and stuff like that. Okay, so if somebody has multiple UTIs or they have a history of multiple UTIs in the past, then we stay away from this medication. And that's an instance where the benefit may not outweigh the risk, because we do have other medications that can still provide mortality benefit. It's not that we have to be on this, okay? But it does have benefit. So if you have a patient who doesn't have a UTI history, you're not worried about that, and you want added protection on top of whatever else they're on for their heart failure, then SGLT2 is a good option. It's a good option. We got that? Everybody understand so far? No questions? Okay. So be careful with urinary genital urinary type infections. DKA, diabetic ketoacidosis, lower limb amputations are some of the rare things we'll see with these agents. And it's not a class-wide effect. What DKA is, the lower limb amputations is more so with canagliflozin than the others. But you may see that from time to time as well. So if somebody has a DKA history, then we don't want to use that. If somebody has a multiple UTI history, we don't want to use that. We're good? Yes? No? Yes? Okay. All right, now the last one I'm going to put on here, and this is more so for completeness sake, A, B, C, D, E, F, is our IR channel inhibitor, ibibradine. I don't see this used very often, but I do want you to know that it has mortality benefit. I'm not going to really focus on that much. We see reductions in hospitalizations with it as well, but I just want you to have it for completeness sake. It'll be on the handout, but it's just not one that's used very often. But it is one that has some mortality benefit associated with it. Okay?
What's IR?
IR channel is just a node in the heart, IR channel. Okay, so morbidity, mortality, benefit. Okay? Now, symptoms. Our symptomatic relief. So these here are often going to come into play. Sometimes patients will already be on this if they're stage A. You know what I mean? Somebody may be diabetic, so you may see an ACE on board because of the renal protection. And somebody may be hypertensive, you may see the ACE or beta blocker or ARB on board for the blood pressure. And then stage B, when you start seeing structural damage, you'll see a lot of these. Beta blockers are pretty good with structural damage in the heart, okay? So these you'll often see with stage A and stage B heart failure. Now we're starting to get to stage C, right? Which is now not only do they have the structural damage, but they also have symptoms. So now that's when we come into the medications that can help with symptoms. Not that these can't help with symptoms as well, but these are more so because of this up here, okay? Symptoms. What are our first class of medications for symptomatic relief? Diuretics, right? Diuretics, okay? Which diuretic specifically? Okay, so not ACTZ? ACTZ? Yes? No? No? Why not? Well, it's going to depend on the edema, right? The ACTZ is not really going to... ACTZ is a diuretic that will cause you to release a little bit of fluid, but it's more so there to kind of help bring your blood pressure down some, okay? But you wouldn't use ACTZ for a patient who has edema. Just like you wouldn't use a loop for somebody who has hypertension that doesn't have edema. Does that make sense? Okay. So the ACTZ, you want to use that in a hypertensive patient, but not a hypertensive patient who has edema. Loops, you don't want to use in a hypertensive patient unless they have edema, because you're going to have somebody who doesn't have edema losing too much fluid. Okay, so our loop diuretics, okay, are going to be very good for our pulmonary and peripheral edema. Okay, with these heart failure patients, we tell them to weigh themselves daily. Okay, if they notice that they're gaining, too much weight and they know it's water weight, then we may need to titrate up that loop diuretic dose. Okay, so our loops are which ones? Furosemide, torsemide, and bumetanide, right? Mostly you're gonna see Lasix, furosemide. But, when I used to work at CVS, I used to work at this one specific CVS where there was a lot of older patients, and their physicians were a lot older as well. And those are the only places I would see like bumetanide or torsemide, because they just had been using them for forever. They just kept the patient on it. But most of the time you're gonna see furosemide. Okay? All right. And what we do is we titrate up until we get to a point where they are not having the edema. Okay? Now, let me ask another question. What is the difference between a ceiling dose and a max dose? Can you speak up? I don't think everybody could hear you.
I just said the ceiling dose is the highest dose that you can give with no further effect.
Right. So oftentimes ceiling dose is actually under the max dose. Max dose is when we're talking about tolerability side effect wise. Ceiling dose is even if you go any higher, you're not going to see any added benefit. So if we reach the ceiling dose of furosemide, if we double that dose, we're not going to get any more fluid, release or whatever the case may be. Okay? So that's very important that you know that, because there's another diuretic. It is a thiazide-like. Metolazone. Metolazone is a thiazide-like diuretic, but it is very, very potent. So it's not like ACTZ. This is very potent. Okay, and oftentimes you should question if you see a prescription for metolazone that is given on a scheduled basis, 5 milligram daily, times, 90 days. You should question that, okay? Unless this patient has really, really bad heart failure, you should question that, because it's usually given on a PRN basis. And more so, specifically, in the patients who have reached a ceiling dose of their current diuretic. So, let me give you an example. Let's say that we have a patient who is on, and I'm just throwing out numbers, okay? I'm not going to ask you guys to know what is the ceiling dose of furosemide. I'm not going to ask you that, okay? But if I say the patient has reached a ceiling dose, then we know what's going on, right? Okay, so let's say this patient's on 80 milligram TID of furosemide, okay? And we say that they've reached that dose, and that dose keeps them pretty stable with their, that's what, 240 milligrams, that's a lot, okay? But that keeps them good. They're weighing themselves every day, and now they see that they've gained 12 pounds, right? We can't go up on the furosemide, right? Because we already said we've reached the ceiling dose, and she explained to us that a ceiling dose, we can't go any higher and see any added benefit. So once that happens, then that's when this can come into play. We can give the patient metolazone, 2.5 or 2.5 or 5 milligram, and tell them to take it daily with their furosemide dose, okay? Until they get back down to their regular weight, then we know that they have lost that excess fluid, and then they can stop the metolazone and just continue with their furosemide. So very, very important to know, you do not stop the furosemide, because if you stop that 240 milligrams and you have 5 milligrams of metolazone, that's not going to do it. It's potent, but it's not that potent. They had to be on their regular diuretic regimen and add this on top. Don't get tripped up. Somehow, some way, I'll make sure you don't get tripped up. Okay? They have to stay on that furosemide, and then you add that on top. And then once that fluid has come off, then you stop the metolazone and you continue with your furosemide. Does everybody understand that? Somehow, some way, I promise you, you'll see that again.
So if happen again, we have to do the same process.
Absolutely, absolutely. If it happens again, her question is that if he takes it and the water weight comes off and he's fine for a month or two, but it happens again, you got to do the same thing. Okay? But what we need to also do is find out why he's having excess fluid. More often than not, you're going to see that he was eating some stuff he probably shouldn't have been eating. And now because they were eating whatever, the fluid has gone up. We got the metolazone on board. We got it off. Now we're back stable. Now don't eat that same stuff again. Okay? Yes?
I was gonna ask if, when you just made that statement about determining why, is that often used in burn patients, like the way the fluid comes back for severely burned patients?
So you're asking if we use
Approach that was ever known to
well, not necessarily. What you see in somebody who's severely burned and they're inpatient, what you're gonna see is they're gonna be given IV diuretics to diurease whatever excess. Adding an oral medication on top of somebody who's getting IV meds, that's not gonna do much. No. Yes, so it's different.
I knew someone who, well, I don't know them directly, but they were severely burned, and at home, they were on the furosemide, and I was just wondering if, on top of that, if they would add.
Well, so now, if it's somebody who is not in the hospital, they're at home, it would just depend if they, because in most cases, they could just increase the furosemide dose, right? But if they got to the point where they reached a very high dose, then that could be an option, yes. Mhm. Okay, so we understand we're gonna go with the loops, right? And then if we need to, we can add this on top on a PRN basis. On top, not replacing. Not replacing. Okay? So our diuretics, furosemide, bumetanide. Okay? These agents are going to help with the diuresis, with the excess fluid, stuff like that. Now, because these are diuretics and they're very potent, we have to be careful with the electrolytes. Right? Our electrolytes. Why? Because you're urinating a lot. So you're going to be losing a lot of electrolytes. Just like somebody who, is playing sports or exercising a lot, you're sweating, you're losing a lot of electrolytes. So you replenish it with, Gatorade or something like that, right? So in this case, we just monitor electrolytes because we want to be careful to not over-diurese somebody. Okay?
You put them on a supplement?
No, we just monitor. And then if we need to, then we can. If they're losing too much potassium, then we can. Okay? Somebody with low potassium, what's the first telltale sign that they have muscle cramps? Right? Okay? For athletes, football players, basketball players, if they're playing their sport and they develop cramps, what do they give them? They give them salt, they give them electrolyte, try to, get that level up to, prevent that. Yeah. So anytime I have a patient on a high dose diuretic, and maybe not even high dose, I always tell them to monitor and let me know if they're starting to develop Charlie horses or cramps or something like that. Okay. So if that's the case, then I do a stat BMP, see what the potassium is looking like, see if we need to add something, or maybe have them eat a banana a day if they're not diabetic. Or whatever. Okay? All right, very good. So, diuretics. All right. Now, next, our digitalis, digoxin. Okay? Digoxin is another one that's good for symptoms. Now, I will say this as well. Digoxin has proven to reduce hospitalizations, but not mortality. Don't confuse the two. Okay? Digoxin is mostly for symptoms, but it has been proven to reduce hospitalizations, but no mortality benefit. No mortality benefit. Don't mix that up. Okay? Digoxin is one of those medications we gotta monitor. Okay? Because digoxin toxicity is something that we can see from time to time. If a patient has visual disturbances, especially like green or blue halos, yellowish halos, that's a telltale sign that they have way too much digoxin in their body. Do a digoxin level, and then we may have to give them digibine or something to bring that down. But digoxin, I want you to know, is for symptoms in heart failure, but it can also reduce hospitalizations. Okay? But let's watch out for digoxin toxicity. Okay? Running out of time. Got that? So monitor the digoxin levels, okay, potassium levels, but keep an eye on, pun intended, visual disturbances. Okay? All right. I'm gonna hit my head on this thing one day. Okay, next up, C, hydralazine and nitrates. And I'm gonna put a star by this one. Okay? Hydralazine and isosorbide dinitrate. What's the difference? Well, I'm not gonna ask that. Isosorbide dinitrate. Okay, the mononitrate is the extended release. But it's the dinitrate is the one that we see in heart failure patients, given 2 to 3 times a day. Okay? Symptomatic relief. Symptomatic relief. The reason why I want to put a star by that is this. Have you guys heard of the drug Bidil? B-I-D-I-L? Bidil? Yes? You work at CVS, Walgreens, something like that? HEB, retail? Okay. Yeah. Throughout pharmacy school, residency, I worked at CVS. And even actually when I was doing clinical, I was still working at CVS PRN. That's how I kind of knew a lot of different things, where it was on the shelf, fast movers and stuff like that. But yeah, I stopped retail when I had started having kids. But Bideal, okay, it is hydralazine and isosorbide dinitrate that has proven mortality benefit in African Americans. It's one of the only drugs that actually has an FDA indication for a specific race. So when we're looking at hydralazine and nitrates for the general population, we're just looking at symptomatic benefit. Okay? In our African American patients, we see mortality benefit. So that's why I put the star by it, because it could fall into our first category if we're talking about African Americans. If we're talking about the general population, symptomatic relief. Okay? So they did the study, I can't remember the name of the study, I used to remember, but it showed the benefit as far as symptoms, but then they did a subset analysis in just the African American patients, and they showed that there was mortality benefit. And so then Pfizer, came up with the drug Bideal. Okay, isosorbide, dinitrate, and hydralazine. We got it? Yes? No? Yes? Okay. Now, this next one, well, we're gonna put that over here, miscellaneous. Our inotropes, I'm not even gonna worry about them because these are gonna come into effect once a patient is inpatient, okay? And with, Dr. Kuhn wanted me to just strictly focus on the outpatient. I think you're gonna have somebody gonna come through inpatient heart failure. So the inotropes, dobutamine, milrinone, those type of agents, those are gonna be inpatient. So we're not gonna worry about that, okay? Inpatient. Then we also have anticoagulation. Okay? Now, anticoagulation for heart failure patients, the reasoning or thinking is when we have all that blood that is pooling in the left ventricle, right? All that blood that's there because the ejection fraction is low. We worry that clots may form with all that blood there. So that's why anticoagulation can be used from time to time. But just know that there is no benefit associated with anticoagulation as far as mortality benefit or even the heart failure just in general. It doesn't provide any symptomatic relief. It's just on board to prevent the patient from having clot. Okay? And so it's going to depend on their CHADS, VAS, if the patient has AFib. But if you have a patient who has AFib and heart failure, you're definitely going to want to anticoagulate. If they just have heart failure, then that's going to be a toss-up. More often than not, they probably will not anticoagulate. Okay, they will not anticoagulate because, of course, the blood thinners have their own sets of issues, right? So that's a risk-benefit type of thing. And what is the true benefit? We don't know, right? Because there is no mortality benefit, there's no hospitalization benefit, morbidity benefit, there's no symptomatic benefit. We're just saying, okay, we have all this blood here, we don't want a clot to form, but we don't know what the true benefit is there, okay? C, statins. Now statins will be on board, okay? Not because the statins have anything to do with heart failure, but just because the statins have proven cardiovascular benefit. Okay, so if you have a cardiovascular patient, right, then the statin would provide benefit to that patient, not to that patient's heart failure, but just to that patient just in general. Okay, so statins you usually will see on board. Okay, especially if the patient has any cardiovascular history as far as like a MI or ACS, acute coronary syndrome, anything like that, then the statins for sure will be on board. Okay? Okay, so let's just review real quick. We got about 20 minutes left. I do want to leave some time because I want to throw out a few kind of quick case-based questions real quick to make sure we all have a general understanding. But I do want to make sure that we understand this. Okay, so remember, we always want to focus on outcomes more so than the endpoints. And our first outcomes we're looking at is the mortality, survival, and morbidity is the hospitalization. Okay, so our ACEs will definitely provide that for us. Okay, we gotta be careful with angioedema, cough, increased potassium, and depending on their kidney function, we may have to stop it. Okay, if they do have the cough, we can always use an ARB. If they have angioedema, we might want to shy away from these two, depends. Okay, but remember, our angiotensin receptor neprilysin inhibitor has added benefit over the ACE. So this is actually the best one that they can be on. Okay.
Is that the go-to now? Like just
Yeah. It is. This is another one that used to be restricted at the VA heavily, but now it's formulated. You can use it, whatever, because of the benefit that we see with it. Okay, so valsartan and sacubitril. Okay, all right. Now remember, if somebody is on an ACE, we gotta wait how long? 6 hours. If they're on an ARB, we don't have to wait, right? But because this has an ARB, we still have to worry about 3 of these. We don't have to worry about the cough, but we do have to worry about the other 3, okay? Because of that in there, all right? Our beta blockers are specific to these 3, okay? Metoprolol succinate, Toprolol XL, carvedilol, Coreg, and bisoprolol was the beta. These are the 3 beta blockers that have morbidity mortality benefit, okay? We gotta be careful with systolic blood pressure as well as heart rate. And if the patient is hospitalized, we have to what?
Discontinue.
Temporarily discontinue it, right? Because it can further exacerbate things. Once they're stable, they can go back home, can put them back on it, okay? But it's these 3, okay? Then of course we have our aldosterone antagonists, spironolactone and eplerenone, okay? Spironolactone you may see gynecomastia, so eplerenone is the better bet to go with, okay? We also have to be careful with potassium and serum creatinine. Our SGLT2 inhibitors, empagliflozin, canagliflozin, dapagliflozin, these all have reduced heart failure hospitalizations, okay? They cause you to urinate out sugar, so we gotta be worried about urinary and mycotic infections, okay? But they do have heart failure benefit, morbidity benefit here, okay? And then our IR channel inhibitor, we're not gonna worry about that, but we know ivabradine does have mortality benefit, okay? All stage A and B heart failure right here. When we get to stage C, we start seeing symptoms. Our diuretics, more so our loops, are going to be the ones we use, and we're just going to adjust the dose until we have they're stable as far as their volume overload. Okay. Now we may need to continue to increase. We want these patients to weigh themselves daily. Somebody gains 5, 6, 8 pounds in a day. We know that's water weight. We need to increase the dose of the loop that they're on. Once we get to a ceiling dose, we can't continue to increase, so we just add PRN metolazone on board until they're back to their regular weight, and then it can go back to just being on their furosemide. Remember, this is on top, this is not replacing. Because these are potent diuretics, we gotta monitor electrolytes. Okay, potassium level drops too low, see some muscle cramping and stuff like that, we need to do something about it. Okay, digoxin. Okay, very good symptomatic relief, reduction in hospitalization. So there's more morbidity benefit with digoxin. Okay, but we got to be careful. We got to monitor digoxin levels, potassium levels, and if there's any visual disturbances, we might be in some trouble. So we might need to do something about that, okay? Hydralazine and nitrate, isosorbide dinitrate, for symptomatic relief in the general population. In African Americans, has mortality benefit. Their brand name is what? Bidil. Okay, so I might ask 2 brand generic. We already said the soprolol is Zebeda, and we said hydralazine and isosorbide is Bidil, is a combination. Okay, and this has mortality benefit in African Americans. Miscellaneous, we're not gonna worry about the inotrope. Anticoag is still kind of dependent. If the patient has heart failure and a fib, then we probably definitely want to anticoagulate. If they just have heart failure, then it's really a toss-up, but more often than not, you probably want to shy away from anticoagulation in those patients. And statins, especially in those patients who have some sort of cardiovascular history, you know, previous MI, CV, ACS, then we want a statin on board for sure. The statin does nothing with the heart failure, but it does reduce, you know, cardiovascular risk, right? So for a patient who already has something, and we're now not looking at primary prevention, but we're looking at secondary prevention, then we want the statin on board for sure. Everybody got that? Questions, concerns, issues? No? Okay, all right. So we got about 15 minutes. Let me say this. Now, there are certain medications that we want to kind of avoid, okay? There are certain medications we want to avoid in symptomatic heart failure patients, okay? Anything that can cause any type of fluid retention, we want to be careful with, okay? So, for instance, our DHP calcium channel blockers, amlodipine, right? DHPs. Amlodipine, and then so all these agents, they cause fluid retention, especially as you titrate the dose up. So these DHP calcium channel blockers we want to avoid if we can in heart failure patients, especially symptomatic heart failure patients, because it can increase fluid, okay? Increase fluid. All right, 2. Our TZDs. Have y'all had diabetes yet? Y'all are P2s.
Yes.
Okay. I do diabetes as well, but I think that's for the P3s. TZDs are thiazolidinediones, pioglitazone, rosiglitazone. These agents as well cause increase in fluid. Okay? So we have to be careful with those agents because they can worsen or exacerbate your heart failure. Okay? NSAIDs. Okay? NSAIDs. Our NSAIDs are, even our COX-2, NSAIDs or COX-2 inhibitors, they all will cause fluid retention. Okay? And then of course, things like androgens, we won't worry about that, but just know these for the most part. Our DHP calcium channel blockers, our TZDs, and NSAIDs or COX inhibitors are going to cause fluid retention, so we want to kind of stay away from them. There are some cardiotoxic medications. Most of those are like your cancer drugs. For completeness sake, there'll be a chart in the handout where all those are listed. Okay, you guys have Dr. Hunter teach y'all? Okay, not yet? Y'all haven't had him yet?
We've had it, but.
Huh?
We have your pain and opioid.
Okay, yeah. He's my classmate. He's really good professor. He does oncology and stuff like that. So, okay. All right. So there are certain medications. Metformin is one. Metformin is almost kind of like, and I only say this because of, Metformin is one that's kind of like a beta blocker. I mean, you know how we said if somebody is hospitalized with heart failure, we have to stop the beta blocker. Metformin is kind of like that too. The patient can, if they're diabetic and they have heart failure, we kind of try to stay away from metformin, but they can be on it. But if they start having symptomatic heart failure, if they're hospitalized, then the metformin has to be stopped. Okay, similar to the way the beta blockers are. The only difference is oftentimes once they're stable and they send them home, they don't put them back on metformin. You put the patient back on the beta blocker, but sometimes they don't put them back on the metformin. They just try to go another route with their diabetic regimen. Okay? We good? Okay. All right. So let's say let's start. Let's say we have a case. I can erase all this. Everybody got that? Okay. So let's say we have a patient who comes to your clinic newly diagnosed with heart failure. Okay? Newly diagnosed. Newly diagnosed with heart failure. What are we going to counsel a patient on initially? Give me some examples. What we're going to tell the patient. And I want you to be specific. Okay? Because a lot of times I ask these questions and students will tell me, oh, we need to, you need to be on a diet. Tell me specifically. You need to do some physical activity. Tell me specifically.
When this happened?
What you say?
When this happened?
I can't hear you.
When this happened?
When did it happen? So let's say they're newly diagnosed in the last, I don't know, maybe month or two with heart failure. Okay? So, what are we going to talk to the patient about? Be specific.
Exercise as tolerated, you want them to drink?
Okay, exercise as tolerated. Okay. What else?
I mean, is it good to recommend some of these people to like a nutritionist or dietitian?
Mhm.
You know, because sometimes it's hard to go back out there by yourself and figure things out.
For sure. But there's some things that we could tell them in the meantime, right? You can tell them in the meantime before they get to the nutritionist or dietitian.
Limit sodium intake.
Limit sodium intake. How? What has sodium? What has salt in it? Like what? Dressings,
Fast food.
canned foods, fast food,
Frozen fries.
all the good stuff, right?
Right.
So yeah, okay, we're gonna tell them, hey, we talked about lean protein, chicken, fish, turkey, not fried, preferably. Vegetable intake, fruit intake, okay, if they're not diabetic. Then we're gonna try to limit our salt intake, and then we will probably want to name some of the things that have salt in it. Okay, I have a patient who says, I'm eating healthy, but they're eating, these Subway sandwiches, ham sandwich, turkey sandwich, all that has a bunch of salt in it, right? So seasonings, ketchup, soy sauce, all these things have salt. I'm getting hungry. I haven't had lunch yet. You guys are hungry too. I didn't even eat breakfast. So yeah, diet, physical activity. Okay, we're gonna do physical activity. Okay, we're gonna try to.
Stop smoking.
If they're smoking, we need to try to do some smoking cessation. Limit alcohol intake. Okay, all right. So now what would we presume that the patient's medication regimen would be like? Let's say they're not symptomatic. They've had heart failure for 2 months. What medications do you think they would be on? An ACE or an ARB, right? Let's say they're on enalapril. Let's say they're on enalapril, they're doing pretty good, right? They come back, you see them in 3 months, and they tell you they have a little cough. Then we can just switch them to Valsartan or Entresto too is an option, absolutely. Okay. All right. Now, so let's say they're on Entresto. Let's say they're on Entresto. Okay, they're on sacubitril valsartan. Okay, and the primary care doctor comes to you and says, okay, I want to put the patient on something else for their heart failure that's going to provide mortality benefit. What are we going to recommend? They're on Entresto. What are we going to recommend on top of Entresto? Beta blocker. Okay, what beta blocker are we going to go with? Okay, so metoprolol succinate. So we're going to put them on. We're going to put. Okay, we won't worry about dosing, but okay. So this patient is on Entresto, and now they're on Toprol XL. Okay, they're doing good. They're stable. Okay, they come back to you. Okay, you talking to them about their diet. They seem to be doing fairly decent with their diet. They're trying to exercise 3 times a week. Seems to be pretty good. They're making the lifestyle changes that we recommended. So they're doing pretty good. But at this point now, they're starting to develop some lower extremity edema, and they're starting to realize that they're a little bit more short of breath. If they walk from the parking lot into Walmart, once they get in, they kind of gotta catch their breath a little bit, right? So now we're starting to see some symptoms. So what are we going to recommend at this point? A diuretic, right? So we said Lasix, furosemide, right? So maybe, I can't hear. Somebody said something? No? Somebody said something. Okay, so furosemide, low dose, and they do stable on that, and and they're fine on that dose. Okay, so now they're on Entresto, they're on Lasix, and they're on Toprol XL, right? Okay, so now the patient comes to you and says, I'm having more swelling than usual, okay? Not a whole lot, but more, okay? What are some questions we're going to ask? What are they eating, right? That's the first thing. There might be some salt involved. Let's say we go through their diet, there's nothing there. What else are we going to ask? What dose of? You know what dose they're on, and you're following them. So and they're compliant and they're taking it.
Like if it's ceiling dose.
No, it's still low dose. Physical activity, okay. What else? How much what? Okay, so let's say it's not much. Let's say there's maybe like 3 pounds. It's not much, 2 pounds. So it's not a whole lot of fluid to the point where you don't necessarily feel like you need to necessarily titrate the Lasix, but you can. What are some other questions we might need to be asking? Yes?
Any type of new habits that people in here.
Okay, new habits. What else? What else may be new besides just habits?
If they're taking any new medication.
Any new medications? Let's say that this patient fell and hurt something, and now they're taking ibuprofen over the counter, right? And so instead of jumping to titrate the Lasix dose, why don't we stop that NSAID and maybe just take Tylenol instead and see if that does it, right? So let's say we do that, they go on Tylenol, and the fluid comes down, right? And so now that patient is stable, okay? For whatever reason, the patient ends up being hospitalized, right? For their heart failure. They were stable, they were fine. 6 months down the line, they were hospitalized. What has to happen with their medication regimen? The beta blocker has to stop temporarily, right? Now they're back stable. Now they're going home. We're putting them back on the beta blocker. So then they come see you a month later. They're on Entresto. They're on a little bit higher dose of furosemide. That's managing the edema. They're on a beta blocker, okay? But now they're on spironolactone. They added spironolactone when he was in the hospital, okay? But he's doing fine on it. He's doing fine on spironolactone. no gynecomastia, no issues like that, okay? We have a chat with the patient, try to see what was going on, what may have caused them to go into CHF exacerbation. And then we come to find out that the patient stopped taking Entresto because it was a little too expensive. And so they were taking Entresto, but then they couldn't afford it anymore, and they stopped. And they didn't take it for a month or so, end up being in the hospital. So now we know this patient can't afford it. What can we do instead? Go to an ARB or go to an ACE. We know those are old and they're gonna be cheap, right? So I just want you to kind of think, because there's always gonna be a lot of different things that you're gonna have to look at when you're dealing with these patients. You know, cost, right? Some of it may be religious. Some of it may be just socio, there's a lot of different factors that can come into play. And so you have to get to the point where, you know, you are asking the right type of questions so that you can get the answers that you need to address whatever needs to be addressed. Got it? Okay, very good. So I think that's it. I will email Dr. Poon today or tomorrow the handout, okay? But you guys just keep that and know that for completeness sake. What we talked about in the class is what you will be questioned on, okay? Somebody have the sign-in sheet anywhere?